We also give didactics to all the anatomic pathology residents. We try to center those less on autopsy techniques and skills and more on autopsy's interface with public health systems in America, as well as some high yield images that they should know regardless of the cases that came through their service while they were on service. There are certain images and findings everyone should know. And we try to relay that because death is unpredictable. So you never know what cases you're going to get. And there is no way if you're on service for a month, you're going to see everything. So we try to bring a little balance to what the residents see.
Welcome to the People of Pathology podcast. I'm Dennis Strank. On this podcast, we explore pathology, laboratory medicine, and forensic science. Today, I'm joined once again by Dr. Nicole Jackson, a forensic pathologist and director of autopsy and after-death services at the University of Washington. Since her last time on the podcast, which was almost 5 years ago, Dr. Jackson has continued to make an impact across forensic pathology, education, and advocacy. We talk about autopsy training, the Society of Black Pathology, some of Dr. Jackson's research work, and the use of social media in pathology. Now, here's Dr. Nicole Jackson. First of all, welcome back. It's been a long time since you've been on the podcast. I looked, it was like September of 2020.
Yeah.
So
Yeah.
a lot has happened since then.
Yeah, thanks for having me. I do remember because I believe I was in the process of relocating to Chicago right in the heart of the pandemic. So it has
Right.
been
That's right. Boy,
5 years. Time is both slowly crawling and flying by.
I can relate to that for sure. All right. So since that time, you've done a lot, and we can't possibly cover it all, but we're going to hit maybe some of the main points, I think. The place I wanted to start, though, let's talk about the Society of Black Pathology, because you served as the president in 2023. And I want to talk about that a little bit. I know I had Dr. Carla Ellis on the podcast to talk about the Society of Black Pathology when it had just started, but that was a long time ago. So let's kind of get an update on that. So can we recap what this society is and what it does?
Sure. So we were founded in 2020 when a lot of us had a lot more time and we're home and we're reflecting, if you will, on our lives, our personal lives, as well as our work lives and careers. And a few of us, all at different institutions, half of whom had never even heard of one another, let alone met, decided that we were overdue to have a society that would represent the unique needs of people in America identified as Black. And so that was the initial thought. Then after a lot of brainstorming and meetings, we founded originally as the Society of Black Pathologists. Since then, a lot of growing pains. It takes a lot of time to form, establish, and then work through all the kinks of a nonprofit, but we did. So we've changed our name. So we are now the Society of Black Pathology. The reason for the change was for ourselves. We wanted to be more inclusive. So it was somewhat of a misnomer. It wasn't just for pathologists. It's pathology. It's laboratory professionals. It's people who do research. And it's not restricted to the U.S. So initially, all the founders, we were in the U.S., but we wanted it open to anyone. So you can be international and join, and you do not have to be Black. So while one of our primary aims is to increase the representation of Blacks and other underrepresented minorities within this big umbrella of pathology and laboratory medicine, we welcome anyone who's in line with our mission. Another aim of ours is we're very big on mentorship and promoting different career opportunities, whether that's speaking engagements, whether that's opportunities to participate in research. So we want it to be a very warm, close-knit community where people are plugged in. We're very trainee focused. So we also try to highlight different summer opportunities, different grants, different sponsorship opportunities for our trainees. So they can have more exposure to these annual meetings you need to go to, right? And summer experiences that will make them more competitive for either getting into medical school, getting into residency, getting into whatever training program is part of their path as well. And then kind of our last pillar is expanding research and health disparities. So that's one I've kind of taken the helm of.
Okay, yeah, and that last one, I think we're gonna get into that a little bit more later on with the article that you published. So then let's talk about your term as president of the Society of Black Pathology. I guess, like, how does, because I know you were involved from the very beginning of the society. What's kind of the pathway into becoming president?
Pathway to becoming president, it was, so Dr. Carla Ellis, she was our founding president 2 years, because the first year, and I touched upon this briefly, there is so much that goes on behind the scenes. So that includes creating bylaws from scratch, revising bylaws, which takes a lot of time to do. You want it to be specific yet inclusive. Words matter, right? And everything. But
Right.
really, when you're talking about something like like the bylaws. So a lot of time was spent with this, trying to figure out, well, what do you need for longevity? We absolutely need to have our funding and our checkbook secured and balanced. What is membership? What does it consist of? What are the categories? What are we going to do to advertise? So then getting on social media, establishing committees, and then all this is unpaid work, volunteer work we're doing outside of all our full-time jobs, right? So
Right.
a lot of it took a lot of time. Of course, change and building things never goes one as quickly as you want to or quite as you expected. So there are a lot of little road bumps here and there, but slowly and surely, Carla led us for those initial 2 years. And then how I became president, I think, was a mix of who felt they had time versus who felt they did not have time. I felt I had time. Whether that's true or not, I don't know, but I think I did a decent job during my year as president.
What would you say were your biggest accomplishments during your term?
So that's a good question. I've been thinking about that. I've been doing a lot of reflection in general. So,
Mhm.
one, I briefly touched upon this. One thing I really thought was important and what I wanted us to do, and I'd seen another organization. It's the Society, I think, of Academic GI Doctors, I believe. I forget their official title, but I noticed I did a little online searching, and I noticed they were very active as a society. And one of the things I liked, they were putting out publications with their organization's name on it. And I hadn't really seen that before. I'd seen individual members, but I hadn't seen a society's actual name on a paper. So that's something I wanted to do, get us a little more prominence in the research space. And so, along with a few other members, I did help draft, and then ultimately we presented it as a lot of grand rounds. We presented it at a national conference, and then we turned it into a paper. It's an article entitled Health Disparities Among Incarcerated Populations, a Crucial Laboratory and Pathology Review. As you know, papers take a long time to write. So that was a year-long process. This was not really I don't know if it made major headlines, but I was proud of it. We joined a partnership with ASCP, the University of Virginia, as well as Immunotherapy Collaborative of Oncology Network Communities, or IC-ONC, and submitted some grants. And what that manifested is we did two very large tumor boards or virtual live sessions with different members. So it was a really nice collaborative. It was educational. I got some of our members out there leading these sessions, and we were able to generate some income from that and put that into the bank to help grow our organization as well. And then the third thing, I was able to get the ball rolling on that name change I mentioned earlier. After going to certain meetings, ASCP being one of them, and having all these laboratory professionals come up, somewhat confused of if they could join or were they excluded. And it really hit home to me that we needed that name change to signify that, yes, you are welcomed. And it was a misnomer, it wasn't intentional, but we do want you. We're all fighting very, very similar struggles, no matter what institution we're at, no matter if you're a pathologist or a medical laboratory scientist or a pathologist assistant. So that name change again took some time because you have to change bylaws and different things and paperworks and checking accounts and websites. But
Mhm.
I was very proud of that.
Okay. Okay. Those are some pretty significant accomplishments. So let's flip that around then. What were some of the challenges?
Time, 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 time. There is not a lot of time. Everyone knows this. He was probably working full time in anywhere in America. And so time, one, schedules, right? And so in 2022, I was already out here being on the West Coast.
Mhm.
Difference is very hard, I'll say. As someone who grew up on the East Coast, I trained all over. There's definitely a slight disadvantage to being on the West Coast in general, just because most people's days are different. The population density is more the middle half of the country towards the east. So just scheduling is hard. And so when it's hard to schedule, the time between meetings tends to increase, and that just delays really getting things done. Or more importantly, I think keeping momentum going, which I think is incredibly important, especially when you're starting out as a small group, a small passionate group. You don't want that fire to die, right? You want to keep it going, you want to keep recruiting people, you want to keep thinking and brainstorming and seeing what you can do. So that was probably the hardest. And then of course, we were still somewhat in the pandemic. It was becoming endemic, but we were still in the pandemic, which
Mhm.
meant people were facing challenges at work. Some people, of course, facing challenges at home. And I think that is one of our probably persistent biggest obstacles. And I would imagine anyone or any organization that's going to represent and largely be composed of members of these underrepresented slash minoritized and marginalized groups, right? We know the statistics that these groups, what they fare poor in their healthcare system, right? They fare poor in natural disasters such as heat waves. So you see that, right? People can't attend things because someone is sick, very unfortunately because someone has died, etc. And if you
Mm.
compare that to maybe either a more diverse group or a group less comprised of marginalized populations, I feel like those occurrences happen less in other groups. Whereas I feel like almost every time I turn around, someone's family member is going through something, and your
Okay.
priority, right, is going to be there. You got to be there for your loved ones, right? Need
Yeah,
to
of course.
to an appointment. You need to, goodness, make funeral arrangements. And so that is a recurring obstacle. But I think it just comes with the territory, and everyone is compassionate and everyone is graceful and understanding and there for one another. And I think that is beautiful. But absolutely an obstacle.
Mhm. Okay, that makes sense to me. You're also a consultant with the Sudden Unexplained Death in Childhood Foundation, or SUDC Foundation. Can you tell me about this?
Oh, I can. So I'm actually a consultant with, so it's a little confusing. So there's a sudden unexplained death in childhood, that's
Okay.
SUDC. And so there's the Registry and Research Collaborative. That's where I serve as a forensic pathology consultant. I was temporarily for a year on the SUDC's board. And so in that capacity, I was sitting along with another forensic pathologist, and we were trying to bring in a research perspective and help them guide kind of how to use their funds for research and how to evaluate different abstracts and proposals. But for the registry, it's something I joined out of fellowship. So I finished fellowship. And one of my attendings, Dr. Gerald, she had been and she still is one of the consultants. And so she basically picked my ear and said, I think you'd be good in this. I think you'd find it rewarding. And so what this organization does, it's centered over on the East Coast at NYU. And basically we get all of these referrals from across the nation of children who basically, usually they were healthy children, well developed, usually hitting their milestones, usually not incredibly sick, who basically went to bed one night and didn't wake up or took a nap or something like that. And so they've already had usually an autopsy somewhere, whether that's in a hospital or a medical examiner's office or a coroner's office. And that autopsy came back essentially negative. So no significant findings, hence the unexplained death part, right? Fully worked up. And so
Okay.
our role, it's a whole panel. of people across the nation. And it's not only forensic pathologists, there are also neuropathologists who specifically look closer at any brain histology, cardiovascular pathologists, so looking at the heart slides more carefully. But what we would do is we review the entire original case. So we look at the medical records, we look at the family history, we look at the initial autopsy, including pictures, including reviewing the microscopic slides. We do that virtually. We also look if there was any infectious disease studies done, et cetera. And then we come to our own conclusion of what the death is. So do we agree that it was unexplained? Or do we think there needed to be further testing done? Was there not enough histology performed? And so we make those recommendations. If everything was done, we think to the best of everybody's abilities and there's nothing else to study, then we basically say what we would recommend targeted genetic testing for. And what this has done a lot of times is sometimes we have a case and we do genetic testing and we get a hit. It's something significant, it's something targetable. That is great because, as we know, there are family members left, usually parents, plus or minus other kids in the family, or maybe those
Mhm.
parents want to have another child, but they're afraid, right? That child, there's something inherited, and that child's going to have the same fate. What also happens is sometimes we'll do the testing and it'll come back as a variant of undetermined significance, not much to do. But if you get enough of those, then you start questioning if those are in fact undetermined significance. They're starting to look significant, right? And so
Okay.
researchers can go test, do different research and try to dive into that. So that's one arm of what we do. Another arm, we're really questioning febrile seizures. So we're taught in med school. People who have children probably know this as well. So sometimes as little kiddos, especially when they're toddlers, they'll have some type of viral illness. They'll have a fever. And they'll have a very brief seizure, and we're trained that that means nothing. It carries no weight, especially if it's uncomplicated or a simple seizure. But what we now have with the advent of new technology in these bed cams that are high definitions, we started reviewing the bed cam footage, or the crib footage.
Mm.
We notice it's a very different seizure that some of these kids have compared to that benign febrile seizure. Very different the way the body positions and the sounds that come out of the body, which is very important and elucidating and something we did not know before this technology emerged. So that's pretty much what we do as a group. Pretty much every year, the group collective gives an update at the National Association of Medical Examiners annual meeting, discussing our findings, discussing opportunities for improvement within our community of medical examiners and coroners, reminding that we exist, asking for more referrals because this is a free service for these families, and we would like to have more people utilize it.
Okay, that makes sense. Kind of get the word out that it's out there for them to take advantage of, I guess.
Yes, exactly.
You mentioned earlier that you're on the West Coast now. You're director of autopsy and after death services at the University of Washington. So tell me about this role. Like, what are some of your activities in this position?
Sure. So I have a lot of activities. So if we go back to the title, so it's autopsy and after death services. So you can view it as two separate but complementary roles. So the autopsy role, I think, is pretty straightforward. So I, along with Dr. Catherine Sherpels, who's my associate director of the service, who is also a forensic pathologist, she's also a neuropathologist. We run the autopsy service. So that means we're responsible for teaching the residents everything they need to know about autopsy pathology. So that's the basics of how to do an autopsy, what is death certification, what is consent, and what's the legal order for consent in our state for the next of kin, what's the difference between a hospital autopsy and a medical examiner, coroner's or forensic autopsy, as well as prepare them for their forensic pathology rotation at the local medical examiner's office, where they will show up and they will be expected to complete an autopsy from start to finish independently. We also give didactics to all the anatomic pathology residents. We try to center those less on autopsy techniques and skills and more on autopsy's interface with public health systems in America, as well as some high yield images that they should know regardless of the cases that came through their service while they were on service. There are certain images and findings everyone should know. And we try to relay that because death is unpredictable. So you never know what cases you're going to get. And there is no way if you're on service for a month, you're going to see everything. So we try to bring a little balance to what the residents see. So that's one role specific to the residency. In addition to that, in that autopsy hat, I am the cardiovascular pathology histology lead for the medical school, which means I am responsible for the teaching that occurs for all first year medical students across WWAMI, which is the Washington, Wyoming, Alaska, Montana, and Idaho 5-state radius where the University of Washington is spread throughout. We also have hands-on gross autopsy specimen sessions that couple with the School of Medicine's teaching. So we have a hands-on cardiovascular lab. So we have a ton of heart specimens and aortas from normal to every type of pathology we can think of. And we do the same thing for the lungs. And we don't only do it on Seattle's campus, but across all 5 states, which means I'm responsible from kind of saving good specimens from autopsy, fixing them. And then my team, I have a team of 5 fantastic hospital employees that help run this after death services and autopsy services. And we batch them out and we send them out across the 5 states. So that's one hat. And then the other hat is the after death services. It's a complex system. So not only do we have 5 states in terms of education, but we provide autopsies to 5 different hospitals within the Seattle area. And then the after death services we provide to 3 different hospitals, all within the UW medicine system throughout Seattle. So that means when someone dies, usually in the hospital, but sometimes in a clinic or a unique location, we are responsible for coordinating, make sure the body is prepared, contacting family for funeral home arrangements, arranging transport, arranging storage of the body. And then when something goes wrong, say a crematorium is down and there's a backlog, doing a little juggling and maneuvering between the different storage facilities to make sure none are past capacity. So that's most of it. I also do research. Of course, I'm in academic medicine now. I do other lectures, both at UW and in the general area. From the service, we also we're happy to. We support multiple different researchers with different grants by obtaining specimens from autopsy that they then use in their labs to do research and study whatever their research interests are. We also help serve to identify controls for IHC. So there's a lot. That's not even an exhaustive list of what I do. But
Oh, wow. As you were describing a lot of those, there was sort of the theme of the importance of the autopsy, right? And I wonder how much of that comes from your training, because you trained at places that are pretty well known for producing forensic pathologists. How much is that do you bring in from your training, and how much is that is just it comes from you, I guess. Does that make any sense?
it does. I think it's impossible to tease out, right? Because
Mhm.
so who I am is so informed, not only by my upbringing as a child, but my training, right? And as you said,
Yeah.
I was very, very fortunate to train at LSU. I trained in New Mexico at the Office of the Medical Investigator. And then I
Yeah.
even, worked in Chicago and then working in Seattle. I've only been exposed to places that have done it well and been supportive. So that's all
Right.
I've ever known. So it's probably a combination of me, but definitely heavily influenced by all these different places I have been at. I think it's impossible to tease out.
Talking about autopsies now, since the minimum autopsy requirement for pathology residents has been reduced, do you think, or have you noticed, I guess, a shift in resident interest or maybe competency in this area? And then what do you think can be done about that?
So I will say in my personal experience, I can't evaluate that because that that reduction happened during my transition. So I never saw the before.
Okay.
I've only seen the after, and I've only seen the after at my current institution. And at my current institution, residents, even if they don't love like the concept of autopsy, they're pretty happy on the autopsy service. It's their rotation to really act independently, take ownership of a case, and they tend to enjoy it. Even if the autopsy is not their thing, they do tend to enjoy it. And again, the University of Washington and our department, we have this our ethos, if you will, for training is we're trying to train well-developed pathologists, in anatomic pathology. That means you're exposed to everything and
Hmm.
expertly in everything. So, and then let the residents decide what they want with their career. And so I haven't seen any type of negative repercussions here at UW. I will say, so myself, I supported Dr. Chappelle's, my assistant director, and we did a paper on this, basically evaluating challenges when it comes to training autopsy at these institutions. And part of that was a survey across the nation. And part of that was specifically talking about this change from 50 to 30 autopsies and what other institutions' experiences are. And there are a range. It made some institutions that don't do too many autopsies. That was kind of a relief, right? They're not struggling to meet the number now. Other autopsy institutions, they do well above and nothing's changing. Some institutions, they are seeing a little more disinterest in residents now. Others are not. So it's really across the board. And I think a lot of that reflects leadership of departments. And a lot of this comes from the top. So if you have a leader who leads with, we want everyone to have an excellent experience in everything, strong training in everything, then there's really not going to be so much pushback. But as we know, there's a diversity of leaders, and some leaders, that's not how they feel, right? They just want to produce certain types of pathologists or people that are more going to go into practices where they're going to be doing research and being grant funded. So it's a mix.
Hmm. Okay. I understand. Something you've been involved with is using EPAs or entrustable professional activities for autopsy training. Now I've heard of this used for kind of general resident training, but not specifically for autopsies. Can you tell me how is this going? How have EPAs improved evaluation, and then how can they be more kind of widely implemented across more pathology programs?
Yeah, so EPAs are, I think, good. This is kind of similar to your other question. Unfortunately, I was not here before EPAs were instituted.
Oh, okay.
Didn't directly see what was happening before. That being said, I have heard about the before EPAs, and what I heard was, residents were not getting timely and specific enough feedback, which is important, right? We want feedback to
Yeah.
not only be good quality, but it has to be timely as well. And so you need both. And it sounded like, and I do not know what evaluations were before, but I think the quality has improved with EPAs, right? And so the way our service does it, we have two different evaluations. So one is the first evaluation that occurs after the autopsy is completed and the resident is submitting the preliminary autopsy document for evaluation by their attending. And so what's nice is that's going to reflect how well did the resident do the autopsy in terms of manual dexterity, understanding what they were doing, understanding, what studies to order. Are we testing for viruses, bacteria? Do we need to do a special dissection? Did they contact the clinical team? Did they relay findings to the family? Things like that. And that's immediate, which means when they turn around and
Mm.
do an autopsy the next day or the next week, they can immediately adjust their behavior or say, oh, I need to focus on X, Y, and Z. The second evaluation, and both of these have EPAs in them, but then the second one is more focused on the entirety of the autopsy. So, based on that initial autopsy, how is this final autopsy document? Is it complete? How well did the resident integrate all these findings? They did microscopy, et cetera. And so now we have two different evaluations. That first one coming out quick, I think, is imperative because then that promotes better learning and training in real time. And then that second one is going to be a lot later because we have weeks to finish an autopsy report. But now
Mhm.
they're not sitting for 2 months. Now they're off service and they have no feedback. So I think that that's a good thing. And I hope more institutions do it because we want to not only have good residents, right? Part of having good residents is being a good teacher. And that is very fundamental to you have to give timely feedback that is good.
Hmm. Yeah, I can see that obviously the benefit to the resident is you said instant or very quickly
Was-
they get feedback, which is important. And on the other side, yeah, as the attending, that helps you become a better teacher, which is equally as important, probably.
Yes, and ideally, I can't watch everyone, but ideally, and this is what
Right.
I do, I give feedback in real time. So in the autopsy suite
Uh,
or at gross organ review or, the next day. But my role is just autopsy. So I'm not covering other services. And we absolutely have faculty that are juggling other service lines. So this at least ensures maybe the attending had to run, do a frozen section or something, but ensures they
mm.
come back in a relatively timely manner.
This is the People of Pathology podcast with our guest, Dr. Nicole Jackson. We'll be right back. Are you thinking about applying to a pathologist assistance program and feeling a little lost? That's why I created the Path to PathA, your PA school application blueprint. This is a step-by-step prep course that gives you everything you need for a strong application. From finding shadowing to writing a standout personal statement to prepping for interviews, this course was made to help you feel informed, confident, and ready. Visit www.thepathtopatha.com to join the mailing list. You'll be the first to hear when the course launches. Your path starts here. LabVine is an interactive online learning platform where laboratory professionals learn, develop, and discover by sharing knowledge and building on each other's experience. The platform provides global access to internationally accredited laboratory-specific courses and other resources developed by lab specialists like us for the laboratory industry. LabVine is free to sign up, and you can use the link in the show notes to get started. Now for the rest of my conversation with Dr. Nicole Jackson on the People of Pathology podcast. Now, you mentioned earlier the paper, Health Disparities Among Incarcerated Populations, a Crucial Laboratory and Pathology Review. And I want to go back to that for a little bit because I read the paper and there's some interesting points in there. So can we talk about what are some of the most important disparities that you've seen? And then let's get into how it crosses over into your work as a forensic pathologist.
Sure. So I don't know if I can say a most important one, right? There, any disparity is bad, right?
Right. Okay.
And so, broadly speaking, and part of the reason we wanted to do this and part of the impetus for this paper, from my experience, and I think many forensic pathologists would agree, if you review some of these records from prisons, jails, you do sometimes question the care that people receive while they're incarcerated, right?
Yeah.
And doing a little research, it's very interesting that those who are incarcerated are the only population in our country that is guaranteed health care in the US Constitution, period. So ideally, people, they enter our carceral system, they should be getting screened. If they already have medical conditions, continued on the medication. And that does happen. But then when you look at these statistics and you look at the morbidity and mortality, you question. So that was our kind of hypothesis is they're not getting the screening and care they deserve. And so one of the most concerning ones, there are so many, but one of the most concerning ones to me are these deaths and diagnoses related to cancers and the fact that they're all cancers that have known and proven screening and surveillance, right?
Mm-hmm.
And these individuals, they are not getting the same screening they would get if they were out in the community and had health care. They're just not getting them. So what does that mean? They wind up being diagnosed at a stage 4, you name it, lung cancer, colon cancer, cervical cancer, right? I mean, that's That's, to me, devastating.
Yeah.
Absolutely devastating, because some of the other ones, they're bad, but we know these public health surveillance works. We know if you get a colonoscopy, at the age of whatever, that's going to increase the likelihood of catching colon cancer early. And we know that is directly related to survival. And yet we see across this country that is not happening. So maybe I lied. That is probably one of the most devastating ones.
Another one that's pointed out in the paper is there's a high mortality rate among formerly incarcerated people, especially, I think it said within the first 2 weeks of release. Can you talk about this and then tied in with forensic pathology? How can that play a role in maybe coming up with like preventative strategies and things like that?
So preventative strategies, and I do encourage people that are interested to read this paper. So I think in some order,
Yeah.
preventative strategy to me would be getting these people who we have, right? They are under the custody of the law, right? So they are not
Right.
going anywhere, which means you absolutely can deliver care. And so part of the issue is a lot of people that are entering our carceral system come in without health insurance, come in without any access to medical care, come in, as we know, with psychiatric illness, because we
Hmm.
know if you walk around the street, a lot of people on the street who are unhoused, there's a big overlap with people with mental health conditions. And unfortunately, instead of getting the mental care they need, they do something, they cause a disturbance, they do some type of crime, and boom, they go to jail or prison, right? And ideally, preventatively, they would be big scale housed. I'm in Seattle, huge West Coast unhousing housed population. It's so big compared to everywhere I've lived.
Yeah.
It's very simple. Give people shelter, give people housing, give people medical care. And it is more complicated than I'm laying out, and I admit that. But, housing people goes really far. Getting people the medical care they need goes far. Yes, there's an overlap with drug use, and that's even complicated. A lot of people who are quote unquote on the street, well, there's a healthy proportion that they didn't start using drugs till they were unhoused. And part of the reason they're using drugs is to stay up at night when you're most vulnerable, right? From someone
Mm.
assaulting or robbing you, and you need to stay up, and then people get hooked. And so it's this like never ending cycle. But yes, housing people would be a great prevention measure. And then once they're in this carceral system, what care are we giving them? And then I think some of it, unfortunately, is unpreventable systems, these jails, these prisons. They are not, feng shui. They are not built for mental health, and they are stressed situations to live in. And stress is bad for the body. And
Right.
just looking at the stress alone, well, I'm not surprised there's an increased mortality rate. I'm not surprised there's decreased lifespans. But then going to your point about that increased mortality within the 2 week release,
Hmm.
unfortunately, a lot of that goes back to drug use. I think this is no shock to any forensic pathologist. We see it pretty frequently, right? Somebody with a drug use history went to jail, went to prison, came out, used drugs, and unfortunately died. And, that's a combination of their tolerance decreasing and perhaps the drug supply changing while they were in prison. You think of fentanyl being incorporated into more drug now.
Yeah. Right.
And so very sad, very devastating, very predictable. Realistically, how do we part of it? And California has been good at this. There are different release models that are centered around, they're called transitions clinic models.
Okay.
Basically, they help bridge that access to healthcare that many of the people in the carceral system don't have, right? So if you don't have healthcare coming in, you can't access Medicaid, Medicare, like you can't buy anything while you're in there, and then you're released. Well, you're released what? With nothing. Then you
Hmm.
need to what? Be employed, right? Because in America, healthcare unfortunately is tied to what? An employer. As we know, now you have a history, so that's going to make it usually harder to get a job, right? So it's this perpetual uphill battle. And
Yeah.
so preventatively, we as a country, we need to do better bridging that gap. We need to do better, perhaps revising our own HR employment rules of who we're excluding. Are we giving people with, say, nonviolent offenses an opportunity for certain jobs? Or are we part of the problem? Right.
Okay.
So those are all potential preventative interventions, and some places are doing it better than others, just like some states are doing better than others when it comes to providing for the people in their carceral system. Some spend almost no money per inmate, and some spend not a lot, but more. And so there's a whole wide range of what is going on in our country, but most of it's not good.
Yeah. Yeah. I got to be honest. When I reading that paper, there was a lot in there that which I'd never heard of, or it wasn't. I guess wasn't aware of. Maybe like for example, you mentioned the lack of cancer screening, and it seems like reading that, it's like, well, of course that should be there. Well, I don't understand why isn't it? You know what I mean?
And, so the interesting thing about this paper, this project, is I was able to I was invited to different grand rounds at different pathology departments the past year. It was interesting at the end, I always open it up for questions and comments. And it was interesting hearing comments from people from other countries and comparatively how we measure. And then
Oh,
some people had friends who worked as healthcare providers, right, to these different carceral facilities. And it's, not a surprise. There are physicians and nurses who work, but there are so few. They are really not well paid and they are incredibly stretched thin, sometimes covering multiple facilities. And so what happens? Burnout, people leave, right?
mhm,
And so
yeah,
the US, we need to incentivize, right? We need to hey, we need providers. We need healthcare providers for our facilities. But we say that as we face a predictive physician shortage. So
mhm,
we have a lot of obstacles in this country.
yeah, that's for sure. One thing I wanted to get your opinion on, because speaking of papers you've written or been part of, there were a couple that you were looking at the impact of social media in promoting forensic pathology. And recently I was asked about what I thought about the impact of social media on pathology education. Like, was it a useful tool? And the thing about that for me, I think that it is useful, but you need to be selective about it, or just because there's so much information out there on the various social media platforms, and not all of it is, I don't think all of it is useful. And sometimes there's maybe an information overload or something like that.
Yeah.
What are your thoughts about that?
So the usefulness or the utility, if you will, of social media as an educational tool, I guess the question boils down to who is your audience, right? And
Oh,
I think just let's talk about just broad speaking pathology. I'll say as a pathology resident, I found social media. I don't know if I would have passed my anatomic pathology boards without social media. That being said, it wasn't that I was using it every single day to study, but what happened was toward the end of studying for those very, very intense board exams, I was tired of reading textbooks. I was tired of reading my own notes, but you know what I was not tired of doing? Getting on my phone, clicking the hashtag path boards, and then just scrolling through these little nuggets of high yield topics from all over anatomic pathology.
okay.
So in that space, fantastic. I think depending on your subspecialty, some do it better than others. I've seen virtual journal clubs. Fantastic. That's educational. I do think it's information overload. I do think pathology is a unique specialty, right? Even if you take a resident, well, those first 6 months of residency are so hard. It's like you're learning a different language, right? And
Yeah.
so I think once you overcome that learning curve as a resident, you can get more out of these posts. Although what I do love seeing is now I'm seeing some of these students who were med students back when I was in residency and now they're residents. They're creating posts that I would say are perfect for people that really don't know much about pathology. So I do think it's a good educational tool. And then when you move over, zoom in on forensic pathology, I think it's an incredible educational tool. I think going back to what's our audience that we're trying to serve, if we're
Mhm.
talking about the general population of anybody scrolling, I think that's where we shine as instrumental with public health, right? You want to talk about gun violence, you want to talk about drug overdoses, you want to talk about heat waves. We're in one now, right? Or at least when we're
Right.
in it. That is great. We know the fatal outcomes of all of that, right? You can do that in pictures. You can do that with histology. You can do it using Canva and these little informational posts that are mainly words and cartoons. But I think
Hmm.
it's fantastic. And people do listen. They do listen because you are a point of authority. People do listen. And then I think what's hard in forensics and probably hard in all of pathology, and it goes back to something I said earlier, is time, right? None of us have time. I think the most time we had was 2020, 2021 when we were home. But now,
Right. Yeah.
people are resuming their normal lives. They're hopefully have and there's just less time, increased workloads, and so it takes time to make a nice, good, educationally sound and post or multiple posts. And so I think that is one of the biggest obstacles. And then forensics, while we do a spectrum of deaths, natural deaths, some of them, as we know, are very traumatic deaths, right?
Yeah.
And personally, I don't want to post something that is going to traumatize anyone. And so my workaround has been posting more histologic images because most people have no idea how to read anything under a microscope. And so that's already going to select for people that understand something about histology. And when you're looking under the microscope, it's usually not traumatic, even if it's blood. Erythrocytes are pretty cute under the microscope. So that's nice. And then other types of education going beyond the stereotypical or what usually pops to mind. I try to post different articles that either I've written, my colleagues have written, or that I've just come across that I thought were interesting and I wish more people would read. I post those. Same thing with podcasts. I find podcasts educational. And so I'll repost different podcasts because I want others to hear that and I want that audience to grow. So yes, I think it's an excellent educational tool.
Okay. Okay. That makes sense. You were talking about kind of the impact of educating people out, like the general public, especially about forensic pathology. I didn't think of that aspect. That makes a lot of sense. And you could really, because there's probably a lot of misinformation about forensic pathology out there in the general public. And so if you're a forensic pathologist talking about it, and like you said, you're a point of authority, that's got to be helpful for the field for sure.
Hopefully,
Yeah.
I think the more positive exposure we get, the better.
Yeah, for sure. This was a very interesting conversation. I appreciate finally being able to catch up with you after so long. Dr. Nicole Jackson, thank you so much.
Thank you for having me, Dennis. Always a pleasure.
If you're looking for another episode of the People at Pathology podcast to check out after this one, here's a clip from the first time Dr. Jackson was on the podcast as we talk about some of the ways forensic pathology intersects with public health.
And there's some public health roles that we still as forensic pathologists that I think people just don't know and don't recognize. For instance, we are intimately engaged with the U.S. Consumer Product Safety Commission. So we have reporting guidelines that help protect the public versus unreasonable risks of injuries from these consumer products. And so when you hear about recalls, it's usually based on accidental deaths that were investigated by us, and we recognize, this is not a safe product for the community. And same thing, we investigate maternal fetal death, analyze mortality in communities. And there's basically a large public health role and value that is specifically and uniquely added by forensic pathology that's not recognized. And why is this important? Because without us basically being well supported and financially supported, over time people are going to die, and they shouldn't. In the short form, right? There simply aren't enough of us.
You can hear the rest of this conversation with Dr. Nicole Jackson in episode 25. All right, big thanks to Dr. Nicole Jackson. I always enjoy talking with her. Throughout our conversation, Dr. Jackson gave us a look inside her role as Director of Autopsy and After-Death Services at the University of Washington, where she's not only performing autopsies, but also helping to shape the next generation of pathologists. She emphasized the importance of autopsy as both a clinical and educational tool, one that supports hospital quality improvement, public health surveillance, and deeper understanding of health disparities, particularly in underserved populations. All of these topics are not given enough attention. The role of forensic pathology in public health was illustrated by the COVID pandemic, which we discussed the last time Dr. Jackson was on the podcast. But it didn't stop there. We talked about a few current examples of the intersection of forensic pathology and public health. One example is her work with the Sudden Unexplained Death in Childhood Foundation. As a consultant for this organization, Dr. Jackson helps review autopsies and contribute to multidisciplinary research that aims to understand and prevent these tragic losses. Her work highlights how forensic pathology can play a critical role, not just in criminal justice, but in advancing public health and support of families. We also explored the deep and often overlooked healthcare inequities within the carceral system. Dr. Jackson walked us through her recent publication on this topic, examining how systemic barriers, like the lack of insurance coverage after release, limited diagnostic access, and punitive healthcare policies, create profound challenges for incarcerated and formerly incarcerated individuals. We discussed Dr. Jackson's time as president of the Society of Black Pathology. Here, she worked to increase mentorship, research, and publications by the organization, thereby increasing awareness. She also led the effort to change the name of the society in order to be more inclusive. Her leadership and her continued advocacy underscore the importance of intentional inclusion and representation in pathology. Dr. Jackson's work shows that forensic pathology is not just about determining the cause of death. It's about uncovering truth, advocating for equity, and giving voice to those who are often unheard. Whether it's through research, teaching, or frontline casework, her contributions remind us that the autopsy table can be a powerful place for justice, education, and compassion to intersect. As always, I'll have links in the show notes to everything that we talked about today. Don't forget you can follow the show at People of Path on both Instagram and Twitter, or just connect with me on LinkedIn. Thank you for continuing to share the show with others. Together, let's inspire the next generation of pathologists and laboratory professionals. This show is a member of Health Podcast Network. Thanks for listening. I'm Dennis Strank, and I'll talk to you next time on the People of Pathology podcast.